All right, welcome to This Week in Health IT, where we discuss the news, information, and emerging thought with leaders from across the healthcare industry. My name is Bill Russell, recovering healthcare CIO and creator of This Week in Health IT, a set of podcasts and videos dedicated to developing the next generation of health leaders. Today, a little back and forth on industry health IT priorities. This podcast is brought to you by Health Lyrics. Want to start your health IT project on the right track or want to turn around a failing project? Let's talk. Visit healthlyrics.com to schedule your free consultation. Our guest today is a retired healthcare CIO and physician and a good friend of the show, Dr. David Bensema. Good morning, David. Welcome to the show.
Good morning, Bill. Thank you for having me.
You know, we usually start with a softball question of, what are you working on? And I will get to that in a minute, but, you shared with me yesterday a woodworking project that you're working on. Do you mind talking about that a little bit?
Yeah, one of the great things about not having a strict schedule, I'm able to do some more woodworking. But I have 4 grandsons, and so they dictate a large portion of what I do. My 5.5-year-old has been obsessed with the Titanic for the last 2.5 years. In fact, he was John Smith for Halloween last year, Captain John Smith.
Wow.
And so he asked me to make a wooden replica of the Titanic. He had seen the replica of the Disney Magic that I'd made for his cousin, and so now he wants this. So I'm hollowing out a large walnut timber to make the hull, and we'll start building the lower decks later this week.
So the two obvious questions are, how does a 5-year-old become obsessed with the Titanic? I guess that's the first question. So how does that happen?
Yeah, so he saw a book in the store that had Titanic on the cover. He decided he liked the look of the ship, and he started having his mom read him things about the Titanic. There are things you leave out when a child is 3.5 to 5.5, and so there's not a lot of discussion about the loss of life.
Right.
But there's a lot of discussion about how it was the most modern ship of its era, and so he has done a little Lego type block replica of the Titanic. He has built cardboard replicas. My basement is strewn with cardboard from his efforts, and just stays with it. And he's an interesting little guy. He's my mechanical genius kid.
Wow, that's amazing. I guess the follow-on question is, do you have to be a grandkid to place an order for one of these ships? I would imagine the answer is yes.
Well, if you're not one of the grandkids, you get way to the back of the line.
Yeah, I would imagine.
And the line is long.
So how are you keeping up on what's going on in healthcare? I mean, are there things you're still involved in?
Yeah, I'm still very actively involved with the State Medical Association and with the American Medical Association. I'm a delegate to the American Medical Association, and one of the areas they look to me for is my experience in health IT. So that causes me to want to keep reading. And one of the other great ironies is I have more time to read now than I have in my entire career. So I probably read 2 to 2.5 hours a day in the industry, and then do some pleasure reading. Right now I'm reading a book, Loathing Lincoln, that was written by one of my old track teammates. And it's about the way over the years that people have chosen to manipulate the Lincoln legacy, whether conservative or liberal, et cetera. It's always been an interesting thing how we twist things, but I have a lot of time to read. I'm enjoying it.
Yeah, I would imagine that would be an interesting dive. So it's been a while since I've had you on the show, and I wanted to catch up with you on the priorities and emphasis that we're seeing in the first half of 2019 from healthcare. And two of the things that we've sort of talked about ahead of the show to discuss. One is social determinants of health, and the other is consumer-centric care. And I'm going to let you kick it off. So I'm going to let you kick it off with, let's start with social determinants, because that was a huge topic at JP Morgan. It was a huge emphasis at the HIMSS conference. And I think a lot of health IT people are saying, okay, I mean, we've been collecting these, I don't think people realize this. We've been collecting social determinants data in the EMR for years. I mean, in nursing notes and those kind of things. So, what else do we need to do? I mean, what's all of a sudden the mass emphasis, and how are we going to get our arms around it and make it digestible, I guess?
Yeah, so one of my concerns is it has been around for years. WHO, the World Health Organization, has talked about social determinants for many, many years. And we know on a macro level that if you look at populations and you determine how they fit into these 11 domains of social determinants of health, you can show evidence that people do better when they're in certain categories and worse when they're in certain categories. But now we're asking primary care physicians or point of care clinicians to capture these 11 domains in a more formalized way because we want to be able to do the data dives. And we're burying the people who are already buried. So my concern is it's a great catchphrase. Everyone talks about it. It's kind of like population health has been. We love to talk about it. There's a whole bunch of people making money talking about it, but no one's really solving it. I think the American Academy of Family Practice has probably done the best job in determining how do we get it into the workflow and creating a conceptual framework for how we bring it into the workflow. But my personal opinion is that the data gathering is going to have to be through a patient-facing interface, registration process, much like they do for their pre-visit registration in MyChart or other patient portals. And then we have a chance of using background diagnostics, background analytics to present opportunities to the care team at the point of care. But if we expect it to be done by the care team and created by the care team, it's not going to happen. We're basically asking people to do what the Census Bureau cannot even do. We do a sampling as the Census Bureau, and now we're turning to the care team and we're saying, do 100%. Do every single patient who comes in, every single American, every single person seeking care in these areas that are really Census Bureau type data.
Right.
How do we make that work better? The AAFP, I think, is on the right track, but we don't even have research that shows that on a microcosm level, we can impact health by knowing these social determinants. We know it on a macro, we don't on a micro.
All right, so I'm going to put you back in the chair. You're going to be the CIO for a health system that's now you were in Kentucky, so let's
Right.
take you to Chicago. I mean, because social determinants in Chicago would be well, I'm sure it is in Kentucky as well, but let's take you to Chicago because there are let's see, there are documented cases where zip code really matters, and you could literally live across the street and have completely different outcomes. So it's a lot of non-medical. So that's why social determinants has sort of escalated in its importance, I guess, right now, plus the push for population health. So I make you a CIO and I say, all right, the physician community is looking at us saying too much data. I mean, you're already asking me to see a patient in 15 minutes. In those 15 minutes, that I don't have enough time to go through all this data and have a meaningful dialogue with the patient about what in 15 minutes in Chicago might be kind. I mean, it might be 8 minutes or something to that effect. So they're going to look to you. They're going to look to you, the CIO, and say, take all this data, and we're now connected. We're getting housing data. We're getting education data. We're getting all this data. I want you to make meaning of it. Where do you start?
Yeah, so I think the first place you start is with much better analytics than we currently have been applying, and analytics that's in the background and then presents prioritizations and succinct opportunities to the clinician, and not more than 3 at a time. And it's kind of like what I've talked about with the alerts. I don't want a ton of alerts. Keep it to a limited list. I'll work through them. If once I've addressed something, it goes into the system and it knows not to bring that alert to me again. Same with these opportunities and social determinants. My team and I, as a primary care physician, can work on the 2 to 3. And once we get them off the list, new ones come up. So better analytics in the background, a more seamless presentation to the physicians in their workflow. And then the big thing is it cannot be on the primary care physician or the specialist to implement a lot of the interventions. A lot of them are social interventions, public health interventions, societal obligations. So we can, as physicians, make the patients aware that they have these opportunities and point them in the direction. But our nation, our system, has to do a better job of providing those resources and making sure they're responsive to the needs of the patient. So but it starts with the analytics. And again, as I said earlier, it starts with the capture of the information, which is going to have to be largely from the patients, recognizing that we have a percentage of the population that is not literate and is going to need assistance. But the vast majority of us can enter the basic information about ourselves, those demographic and address type informations.
It's interesting. Do you think we'll see a lot of well, I mean, because one of the areas this really gets highlighted in an urban setting is in the ER, because you have a lot of people present in the ER who, quite frankly, it's a result of neglect over time of addressing some of those core social determinants. And one of the things our physicians were asking for was it's too hard to find all this data within the EHR. Now, we can argue which EHR is better at that or whatnot, but none of them are great at it. And so what they were asking for was an overlay. They were asking for something where they could get a quick snapshot. And obviously behind that is a whole bunch of integration so that you can pull that data out of the EHR, a whole bunch of analytics, be it predictive or retrospective analytics, be it machine learning or AI, the buzzwords on top of it. But regardless, it's all analytics. And then you're presenting that in almost like a red, green, yellow kind of thing, so they can look at it and say, there's a housing issue. And it almost has to be single click, like, okay, I'm going to make just like you're prescribing medicine, you're like, I'm prescribing housing and urban development to help you out, or whoever it is, whatever the agency. But it has to be fast, and it has to be simple. It can't be the doctor sitting down and saying, hey, let's talk about your housing situation. Oh, you don't have air conditioning. That's not really going to be their role, probably, I wouldn't think.
Right. But I think you're right. It needs to be presented in the workflow, much as we do with opportunities for immunization, opportunities for screening exams. In the system that I was with, Baptist Health, they're now using the EHR to present to the physician at the time they open the patient's chart, those opportunities, and it's presented to their medical assistant, and there's opportunities where those can be ordered by the medical assistant to be confirmed by the physician. We're trying to simplify doing the right thing, and we've seen our screening rates go up since the implementation of the integrated EHR and providing that. We need to do the same with the social determinants, not expecting the physician himself or herself necessarily to address those, but their awareness, and they're pointing the team to say, what can we do, or where should we refer? That can be done by the whole care team. It can be done at the discharge desk by clicking on a couple of those social determinants. It then tells the discharge person, make sure they have an appointment with social worker, make sure they have the address and a contact at the food bank, make sure they have, whatever, a contact at the gas company so that they don't get their gas shut off, they have heat. Yeah. Those things can be done in the workflow. We just have to present them better in the dashboards and make it be as simple as one click. Anything more complicated, it's not going to happen. I did primary care for 16 years, and I was overwhelmed in 2006 as I was finishing up my primary care. I can't imagine being my colleagues now.
Yeah. We have to make meaning of the data. There's going to be more data than ever. That's the role of the CIO, Chief Information Officer, to do something with that. So you referenced a framework that has the 11 categories. What's the reference for that?
The reference is the Perspectives in Primary Care. It's a 2016 study by or editorial by the American Academy of Family Practice. It's in their journal. Let me see if I can quickly give you the actual date. It's Annals of Family Medicine, 2016, colon 14, colon 104 through 108.
Okay.
So it's volume 14 of the American Family Medicine Journal.
All right. So social determinants of health. Here's the thing I like about this conversation is we were talking about interoperability almost the same way we're talking about this now, maybe 5 or 6 years ago. It was a huge hype at HIMSS. Chime, we were talking about interoperability. If you went there this year, interoperability was a huge focus, but it was more showcasing just a ton of solutions around interoperability. And we haven't tackled this problem to the ground, but there's been so much momentum on it that you're starting to see solutions rather than people sort of throwing their hands up saying, well, you can't do interoperability in healthcare. And I think the same thing's going to be true here. You have this escalation phase where everyone's talking about it, and the community's going to go about solving this problem. And I think in 2 to 3 years, we'll have a new problem to solve. But social determinants will be something that we have hopefully wrestled to the ground in a few years. That's my hope.
Yeah. I think from a knowledge base and any presentation base, I think you're going to be right. I think from the real solutions, that's a huge social lift that's well beyond you
Yes.
and I and the IT world.
Well, and it's non-medical, right? So it's way beyond healthcare as well. I mean, there's so many institutions and agencies we got to figure out data sharing across that. We got to figure out referrals across that. So we're creating all sorts of new patterns within healthcare, and it's good. It's just going to take some time.
Yeah.
So consumer-centric care. You brought this one up. I'd love for you to tee this one up.
Yeah, so consumer-centric care is another one of the catchphrases of the last year and a half. And when I hear it as a primary care physician, CIO, I hear it thinking it cannot be consumer because patients come different than a consumer. If I walk into my local appliance store or my local auto dealership, I'm truly a consumer. I'm able to be informed about the product, come in with my money. I know how the interchange is going to happen. I pretty much control a large portion of that interaction. And the most important thing, I don't need either of those. I may want those things, but I don't need them, so I can walk. As a patient, I need care, and I come fearful, and I don't really understand the pricing. And even with posting the charge masters, I still have no clue what the pricing is for hospital care, and no immediate ability to fully understand that. No one's going to immediately understand all the abbreviations, the codes. Even if you put it out as DRGs, it's just hard for the patient to really understand it, and particularly in a moment of stress. So I kind of rebel against the consumer-centric. I think we need to think more, how do we care for people holistically and in a way that does work to delight them? I mean, the consumer catchphrase of a couple of years ago was delight. Anything I present to people should delight them. Well, I always thought that way about my practice. I always wanted a patient leaving anxious to tell 5 more friends, you need to go see Dr. Bensema. And if you approach it with that attitude, then you are always going to be focused on the patient. Now, that doesn't mean you give them everything they want. It means you explain your rationale and you engage them and partner with them in that care. But to call it consumer-centric, I just think is a misnomer.
Yeah. It's interesting. You brought that up. I haven't really thought about it in a while, but when we were developing our models around this, I would say about 6 or 7 years ago, as CIO, we always kept consumer and patient separate. And the reason we kept them separate, one of the things we identified was there was 1.5 million people in Orange County that we didn't see. And we just called them consumers. They didn't have a medical record. We didn't see them. And we said, but we still have to care for them. What category do we put them in? Well, they're a consumer of health, but they're not a patient. So let's just call them consumers. But we had a clear delineation that once they came through the door, they became a patient. And so there was different strategies, there was different technologies, there was different approaches to how you care for somebody who's not a patient. versus how you care for somebody when they become a patient, and not a whole new set of tools, but a lot of the tools are very different. You go from, hey, we're measuring stuff on an Apple Watch over here to, hey, we're actually going to connect them to an EKG or ECG over here. I mean, the tools are different. The technology is different. How you're measuring it over here in the consumer world in a database that's outside the EMR. But once they step through the door, now all of a sudden you're trying to push as much of that data into the EMR because that's into the workflow. So we tried to keep those two things distinct. But I can understand. I understand where you're coming from in that if there's not a clear delineation, and we're trying to treat people as consumers after they've walked in the door, maybe from the perspective of they have a choice and you want them to be happy, that's great. But doctors have to say some hard things, right? I mean, people aren't always going to walk out happy.
And so we used to talk to our system about the fact that the consumer-centric was the marketing aspect. It's how do you get a community presence? How do you make awareness in the community and trust in the community? How do you develop that, whether it's through Facebook, tweets, newsprint? All those things that marketing does is to create this element of trust. My job, once the patient comes in, is to focus wholly on that patient so that I fulfill the promise that was created by the marketing, but I'm taking care of the patient. And my concern is that we've talked a lot, and I think there is value to bringing some folks from outside the healthcare industry, but they've got to be strongly supported by a team of deep healthcare experience who's then open to innovation, open to new ways of approaching things. But you can't just turn it over to somebody from outside the industry because they've had success somewhere else in the consumer facing aspect of their industry. They're not going to understand the nuances of healthcare. They're not going to understand the incredible responsibility of that trust relationship that begins the moment the patient starts to register. Yeah. And once that patient is chosen to receive their care in your system, or is forced by showing up in your ED to receive care in your system, that patient becomes a holy trust for your system.
Yeah, absolutely. So let me talk to you. So there's an article released today, which will tell you when we're recording this show, even though it's going to be released on Friday. But cardiologists say Apple is overselling its health rollout as FDA applauds, and it talks about how Apple's touting their watch as a detection system for AFib. Critics are concerned that the FDA's unusual celebration of Apple's new technology, which is central to Apple's rollout. The concerns center around the algorithm accessible through the Apple Watch, which detects AFib, an irregular heart rhythm that can elevate some individuals' risk of stroke. In many cases, the watch has given users warnings that led them to get necessary and even life-saving medical help. And it goes on, it cites a nurse whose daughter had kidney failure, and the Apple Watch predicted something that they didn't see. And in CNBC, users are telling me they found a problem with their heart they didn't even know existed, and if they wouldn't have reached out to a doctor, they might have died. These are life-changing things, Cook said. Cook, who's the CEO of Apple. But doctors are worried that when used by millions, the AFib warnings could lead to unnecessary, even harmful medical care. That's why Apple's marketing of these success stories bother them. And it goes on to talk specifically about cardiologists are concerned many people using the Apple Watch might respond to detection of AFib by unnecessarily seeking treatment. To date, the benefits of treating the condition have been proven only in certain at-risk populations, such as elderly and hypertensive and diabetics. It's interesting because this post, I saw this on LinkedIn this morning, and the people who commented on it were all physicians, and it was all, see, this doesn't work. See, there's no research studies. There's no proof that this is going to work. But from somebody who's a technologist and somebody who's actually wearing an Apple Watch, and I see the benefits to the consumer. I understand that once they become a patient, I'm not going to prescribe an Apple Watch and say, hey, this is how we're going to monitor your health. It's not there yet. But for the consumer world, I would think it's a decent thing to have that little thing say, hey, you might have AFib, call somebody and talk to them.
Yeah. Yeah. So my take is, number one, Apple has done a more thoughtful job than a lot of the app developers, a lot of the folks that, there's a lot of trash out there and we're aware of it and we want it to be cleaned up. But I'm also aware that anything that increases societal awareness of their health and improves their focus on preventive health or altering their health status and their health risk profile, I'm all for. And so the Apple Watch has some potential benefit there. I don't care for practicing anecdotal medicine. So, the testimonials are always, I'm leery of it. And so my physician colleagues, I understand their kind of backlash against that. And I understand the need for studies, but I also understand that getting a patient in who's concerned because my Apple Watch told me I have AFib also gives me, as a primary care physician, a chance to talk to him about, yeah, and you're 35 pounds overweight and you're really more at risk for type 2 diabetes and you probably have prediabetes. Let's work on that. And probably as I get you to do more exercise, this question of whether you have AFib or not will resolve itself. Now, having said I don't like anecdotes, on an EKG, I can get the algorithm to read me as AFib simply because my resting heart rate is 42 and I have a respiratory variation. So I'll drop as low as 26 and go up to 50. And in doing that, I have irregular spacing of my QRS, which is the little spiky part of the EKG. And the algorithm reads me as being in AFib when I am in total sinus bradycardia induced by my lifelong running habit. So, that's the risk. But, let's talk about it. Patients, for the most part, are going to be able to understand if I take the time to explain that to them.
Yeah, I mean, my initial response to this was they're seeing doctors and they're saying, hey, they're asking for unnecessary tests. Well, as the doctor, I mean, your thing is to say, we can do the tests if you're concerned about these things, but let me explain to you what AFib is. Let me explain to you where it comes from. I just don't see the downside.
As a physician, my job is discerning. As the patient, your job is to get in when you have a concern.
Here's where I think the doctors have a really good point, which is the analytics. The analytics have become a black box. So what's it reading behind the scenes and then spitting out results to a patient and saying, hey, you might have X, you might have Y. And this is the area that I think we're going to see a lot more pressure on these tech companies, and especially the data companies. The Amazon wants to get in, they are in. Google and Amazon are in, Microsoft's in, and you're going to see a lot more pressure, I think, on really exposing what the algorithms are looking at and submitting those to really to some academic rigor around, are these accurate? Are they actually predicting what we think they're predicting? Because people are going to start people can make mistakes, so can algorithms. And having them be behind the scenes and it's like, hey, don't worry, we trust Google, they're going to give us good stuff. No, I understand some of that's your proprietary information, but if you're going to be treating people, that comes under the FDA. If you're going to be making recommendations, and
it becomes a medical device.
Yeah, they skirt that closely by saying, well, we're just making a recommendation to the doctor. But either way, I think we're going to see a push to.
Yeah, and they even call it just creating an awareness as opposed to a recommendation.
Yeah, it's interesting. If I were bringing these tools into healthcare today, one of the things I would probably require is, all right, I don't want you, I'm not going to put me under NDA, but we need to be able to look at your algorithms. We need to be able to look at how are you generating that green light? How are you generating that red light? And
sure. And at the same time that we're talking about Google and Apple and others coming under that type of scrutiny, and I totally agree, we need to do the same as a medical profession with our care guidelines, because so many of them are really just a rehashing of what has been historic care, community care standard, but that doesn't necessarily mean it's evidence-based. We need to subject our care guidelines to evidence-based good research, just as we're going to ask them to submit their algorithms to good validation research, then our patients benefit. I mean, the bottom line always, and you've heard me do this before, I always come back, what's best for the patient? It's not a matter of, me getting to do my procedure because that's what I do. A man with a hammer is going to pound nails, or me getting to make money, or me getting to stand in front of my shareholders and say, here's the dividend, and here, we supplied this dividend. It has to be what's best for the patient. And we just have to always come back to that as our core conversation. I did that as the CIO with my team. I said, each of you is as much a part of the care team as the clinician at the bedside. And you always have to think about, how am I impacting, how am I benefiting the patient? And the team finds inspiration in that. And I think our IT colleagues find inspiration in recognizing that that's who they are. But we across the industry have to keep the patient first in our mind. Back to the consumer-centric, back to patient-centric. Patient has to be the reason you're doing it.
Yeah, absolutely. David, as always, great conversation. I guess the next time we'll see each other is in the desert at the Scottsdale Institute. And
very much looking forward to that.
Yeah, I'm looking forward to it as well. And we will get out on the golf course and show each other how little we have played and practiced our golf game over the years. It should be fun.
Should be very fun.
This show is a production of This Week in Health IT. For more great content, you can check out the website at www.thisweekinhealthit.com or the YouTube channel at thisweekinhealthit.com/video. Thanks for listening. That's all for now.